Have to hear from Rob Ritter. Are you ready? Here he goes. Rob Ritter, everybody.
Hello? Thanks, Sandy. Okay, let me grab this. Hello, everyone. I want to say, first of all, thank you to all of my friends and special mentors who are here today. There's a lot of you in the crowd, and it's great to be here. And to Michael Cohen and the whole Seattle Study Club for having me. I really appreciate the opportunity to spend some time with you today. I have a limited amount of time, so I'm going to jump right into it. One of the great things about doing one of these sort of showcases or a 20-minute presentation is I get to go through some real meat instead of fluff and get right to it. And you're going to see me play off of some of the information that we saw this morning from both Avishai and from John. Now, before I jump into the dentistry, I do want to mention this. The reason I'm here today, besides my partner practicing in the office and keeping the numbers rolling, is my family. And they couldn't be with me today. However, without my wife and without my daughter, I couldn't be here today. And quite honestly, on bad days, and I do have them in my practice, when I come through that door and my daughter comes running through my house into my arms, it's the best thing in my life. It's the most important thing in my life. That's my love. I have a passion for dentistry, but my love is my family. And the reason I also put this up here is because my beautiful daughter, Olivia, is a product of technology. She's an IVF baby. And I do thank God every day for that, because without technology and without moving forward, I wouldn't have her in my life, and my life wouldn't be complete without her. So I can't be with her this week, but I want you to see what we're all about, because I do have a life outside of dentistry. Okay. You know, this morning, some of my mentors who are here, like Bill Robbins, Jeff Rouse, talk about vertical maxillary excess. And we look at short teeth, and we look at longer teeth and too much maxilla. And we also talk about interdisciplinary treatment planning, where I work with a periodontist to get rid of the vertical maxillary excess and take this girl, who is now a woman, doing what we call, I like to call it selective reduction. I don't like to call it minimal prep. I don't like to call it no prep, because there is no such thing, into something like this. And yeah, I love to prep teeth and do it as minimally as possible. In this case, I'm literally removing off 0.1, 0.2 millimeters of enamel, keeping it all in enamel. And the whole idea is that we're able to do some very, very minimal dentistry for this young woman. And these are actually pressed lithium disilicate. There's an article that I just did on this. We're able to take lithium disilicate now down to 0.2, 0.3, like Avishai said. And so now material selection is off the table. What we're able to do is take this young woman and turn her into, for me, a very pleasing moment in my career, which was I was just on the cover of the Journal of the American Academy of Cosmetic Dentistry. And within this magazine, there's also an article on me using lithium disilicate pressed down to 0.2, 0.3. And a lot of care is taken to acquire this type of information, and so I would refer to you the article for you to take a look at. And yes, I do veneers, but as we just know, as we just noticed from Kirk's wonderful presentation, it's the percentage of my practice now. The majority is general dentistry every single day. And Michael has set up a great program about general dentistry, so that's what I'm going to talk to you about today. We're going to talk about glass ionomers and its role in dentistry. Now, I think on Wednesday, Kim Cooch is going to be talking to you about Canberra. And I'm not going to spend any time on Canberra, because I have the very, very initial part of it, which is sealants and glass ionomers. We seal teeth now. I've been using a lot of Fuji triage, and we'll talk about triage here in a moment. And what we do is we're able to seal teeth. The reason why I put this reference up also is Jason Wannick is in my town. He's a pedodontist, and he did the study on this. And this is what we use in our practice now. We use Fuji triage. Well, there's a whole bunch of reasons why we use Fuji triage. I don't have a lot of time to go into it right now. We'll get to it later in the presentation. When it comes to glass ionomers, this is the most underutilized restorative material we have here in the United States. I've been very lucky to travel all over the world and lecture, and in other parts of the world like Australia, New Zealand, and in Europe and South America, glass ionomers play a very large part of general practice. Here in the United States, when they came out, they were overutilized. They were utilized in areas where they shouldn't have been, and they failed. And what happens to the American dentist when something fails? We slam our hands on the table and say, I'll never use that again, it's a failure. Well, it's because it wasn't used correctly. Of course, I believe in, if all you have is a hammer, everything looks like a nail. The three companies that produce the majority of the glass ionomers are GC, 3M, and SDI. And I don't promote one product over another, but I will show you two clinical cases today. What I want to point out to you is the differences between composite and glass ionomer. Composites are tooth-colored, and while glass ionomers are tooth-colored, they don't have the same filler material that true composites do. They don't reflect light the same way. So make no mistake about it. While you will see delineations that say A1, A2, A3, B1, they don't look exactly like true composites do. Composites are higher strength, glass ionomers are not. They just don't have the sort of inherent strength that composites do because of the resin matrix. Composites, after you work with them a while, are fairly easier to place, whereas glass ionomers can be more difficult. We'll talk about that in a few minutes as well. Composites don't release fluoride, and that's the major advantage to true glass ionomers is the massive amount of fluoride release. Where we use these is the key to fluoride release, and then bonds to dentin. Now, composites themselves don't bond to dentin. Of course, what you have to use is some sort of an acid conditioner with an adhesive, and then yes, you can bond to dentin. And while it's fashionable for some of our mentors to tell us that you can't bond to dentin and that it's a temporary seal, of which some of my temporary seals are now at 14 years, which is longer than some marriages, I think that you can bond to dentin. Glass ionomers do bond to dentin, both ionically and covalently, and we'll talk about that in a few moments. Now, true glass ionomers I want to delineate. We have glass ionomers, and then we'll eventually talk about resin-modified glass ionomers. True glass ionomers themselves have no resin in them whatsoever. You cannot light cure true glass ionomers. They are auto-cure, they self-cure on their own. The types that I use right now, some of which are from a company like GC, which were Triage, let's go back here, Triage White, Fuji 9 Extra. Now, one of the things about Fuji Triage, which was made by a dentist, his name is Jeff Knight from Australia. And Jeff Knight kind of talks like this, and you got to use Fuji Triage on everything. And of course, we don't use Fuji Triage for everything, but what Fuji Triage does is it has 9 times the amount of fluoride release, which is very interesting. You don't need to pre-treat the tooth structure, but you do use it to replace decayed tooth structure. The other type of glass ionomer is more rigid, which is Fuji 9 or Fuji Extra. Now, the great thing about glass ionomers is the ability to heal teeth. And we've seen this a little bit before. The speaker, a couple of speakers before said, let the body heal itself. Well, yes, that's a great idea. Something we don't do here in the United States. In the United States, whatever there's disease, we remove it. We don't let the body heal itself in dentistry. Well, I'm here to tell you that in other countries, they've been doing this for many, many years. What happens is it forms a semipermeable membrane. It lets some of the acids in. It also lets calcium and phosphate in to react with the fluoride, and basically you remineralize the actual tooth structure itself. I like this approach. I'm going to show you a case where we use both Triage and Fuji 9 Extra. This is a 14-year-old girl who comes to our practice who has interproximal decay right here. Now, in most practices, you have a couple of options here. Some practices would do a Class 2 amalgam. Some practices would do a Class 2 composite. I'm going to show you something else that might stimulate some thought. Because this tooth is next to another tooth that has the beginnings of a lesion, I want to bathe these teeth in fluoride as much as I possibly can. So what do? We anesthetize the teeth, and we place it under a non-latex rubber dam, and we remove the decay. Now, I'm getting fairly close to the nerve, and in fact, I leave some of the demineralized dentin itself. I don't want a pulp exposure. What I utilize here is a Garrison dental solution ring. And there's a couple of ring systems out right now. There's one from Garrison, there's one from Triodent. We have both in the office. And what we do is we place the wedge and the sectional matrix in, because these give you fantastic contacts after they're done. And what we have here is a cleaned out area that we've used some surface conditioner, something like you can use just regular chlorhexidine or chlorhexidine soap to remove any of the bacteria out from the tooth structure. Now, in this case here, I am not going to pre-treat the dentin with any sort of acid